Okay.
Sounds great. All right. So, just as Dr. Matthews said, I recently completed my PhD in biomedical engineering from Duke. After that, I was a visiting researcher in the AI and health group at Google Research. After that, I was awarded the Margaret Butler Fellowship in Computational Science. And right now, I'm a fellow in the Leadership Computing Facility at Argonne National Lab. And the title of my talk today is going to be towards developing digitized patient twins using massively parallel computational models and artificial intelligence algorithms. So let's get right in. So, just as Dr. Matthews said, it is becoming increasingly important for medicine and clinical sciences to accept, computational science, which is against what has been traditionally practiced. This is also witnessed by the current initiatives that NIH has taken. The Bridge to AI program is estimated to be over $100 million to be spent in, just a span of 4 years, because they really want to push through some of these boundaries. And if we start at a very, very high level, in this talk, I'll be going over, three broad agendas. So keeping, the healthcare structure in mind. So when we think about healthcare, there are two key stakeholders, right? There's physician and there is patient. So for the physician side, we will be talking about what kind of models are we developing, to empower physicians with the predictive power so that they can enable going from a computational method all the way to deriving clinical parameters, something that they use in the clinics day in and day out. On the other hand, in the second part of the talk, I'll be going over how we can empower patients using AI driven tools to enable self-management, for example using smartphones and wearable devices. At the intersection of patients and physicians lies the data. And as I'll go through with some of these aspects in my talk, in order to enable some of these models to go towards applications in clinics, we really need to develop some synthetic models for creating these digital patient twins. So getting started right away, cardiovascular diseases, the group of disorders, as we all know, that concern heart and blood vessels. Now, there have been several, for a lot of decades, lifestyle modifications, advanced diagnostics have kind of helped in curbing the burden of disease shared by CVD. Yet, despite all these advancements, the current burden remains highest for cardiovascular disease. It is still the leading cause of death worldwide, not just in the United States. That being said, coronary diseases, the vessels that supply blood to the heart, they constitute about 45% of overall deaths. Despite these advancements, a large proportion of, for example, 50% men and 64% women who die due to CVDs, they have not been previously detective of, of any kind of symptoms. So one of the things that lies at the very center of this disease area is that blood flow patterns within coronary arteries gets changed, which results in modifying some of the hemodynamic forces that affect these blood vessels, which further leads to the development of coronary artery diseases. One of the ways in which we can interrogate these blood flow patterns is using personalized computational fluid dynamic simulations, which is a computational framework. So at a very, very high level, this schematic, even though it seems like a pretty heavy slide, but if we just walk through it, we'll be able to understand how, we can employ and, integrate this clinical data within these computational models. So if we start at the very top on the left, when patients, they undergo hospital visits as such, there are several diagnostic techniques, electronic health record data that gets captured, that is continuously collected over the period of, patient visits to the doctors. With that, we apply some data cleaning and data processing techniques to develop these, arterial models of patients. Once we have these models, which are personalized to a specific patient, we can use them as inputs along with other data sets. For example, age, velocity, blood pressure, and things like that. Once we integrate all of these variables in our model, what we get is this personalized fluid dynamic based solver. This solver is just a bunch of mathematical equations and it uses computing power as shown here. Having these two things integrated, what we can get are these physiological maps, what is happening inside the patient deterministically. And then we can have this non-invasive assessment of clinical diagnostic variables, for example, pressure, volumetric flow rate, and things like that. Having access to these in a non-invasive fashion, we can validate these results by comparing it directly to clinical data sets. And in addition, we can allow them to give it to doctors back so that they can interact with the physiological maps that we've provided, which can further result in allowing that predictive power, which we were talking about at the very beginning, giving physicians that predictive power to know what is happening inside of the patient without really putting a needle or having any kind of an invasive procedure. So traditionally, computational models that I just talked about, which are these high-resolution fluid simulations, they have two components. The first is a fluid dynamic solver, and then the second is a medical imaging technique. Between these two components is what we need, how to make a good computational non-invasive framework for allowing us to determine these diagnostic variables. And I'll talk about both these parts. For this work, we relied on the Lattice-Boltzmann method, which is essentially using the Boltzmann equation to solve fluid patterns inside within the blood vessels. There are several other methods out there. Some of the reasons why we like this method was because it allowed us to captivate on that incredible parallel power that is given through supercomputers, because that really helps in giving us results in real time. Unfortunately, we in order to have that incredible compute available to us, we need these memory light implementations of such methods. And within the world of computer science, when we say memory light, what we really mean is to reduce the memory footprints, which is measured in bytes. I wouldn't go into too much detail here, but the idea that I want to put across is that we want to alter these algorithms based on what clinically is going to be relevant for physicians when we hand over these models for physicians to use in clinics. These are some of the results that we got from our model. When we implement a model and we run it on say, a big supercomputer, if you look at this plot, what we're really able to find here is that, I'm not sure if my cursor is available. I don't know if you guys can see it. Is it available, Dr. Matthew?
It's available.
Okay, excellent. Yes. Thanks. So what we see on the x-axis are the number of compute cores, which is number of CPUs, for example, that is available to us. And the goal would be here that as we increase the number of compute cores available to us, the time to solution for our simulation should go down. And what we see here and call in the world of supercomputing is that we're seeing almost linear scaling. So the more compute that is available to us, the faster our simulation is going to be of implementing these models, for example, say at scale. And what we can get are these velocity profiles of patients. The other component that I mentioned before was the imaging modality. Just as I said before, the imaging modality is important to us because this is what is going to personalize the simulation along with the EHR data that we get. For our purposes, we wanted to rely on an imaging modality that is extremely high resolution. For example, say coronary angiography. Not only is it the gold standard for diagnostic measurement of coronary arteries, but it's also important to note that over 1 million catheterizations are performed just in the US. So if we have access to, say, a lot of data of CA, we can actually scale up these models really quickly and build and start doing some of those population studies. So against what is a traditional norm of using, say, CT angiography, we wanted to use coronary angiography. So the idea here would be that once we have access to say these pipeline angiograms, we would apply a reconstruction algorithm that would create a 3D patient-specific geometry, which we can have as an input to our fluid solver that we just saw, which scales really well on these massively parallel systems. And what we can get are these, personalized physiological fluid maps. But again, at every point of this talk, one of the things that I would like to emphasize on is validation, because that's how we want these models not just to be fast. We don't want these models to, but we want these models to be trustworthy and robust. So as a first stage step, we wanted to say that the models, the 3D patient-specific geometries that we're getting, are they, how accurate are they? So we compared these models to a 3D printed angiogram phantom model, and then we compared how are we doing with respect to the accuracy of the model that we have reconstructed from these biplane angiograms. And we were pretty, we do pretty good for, it's not just qualitatively similar, but even from a quantitative standpoint, we got an average distance deviation between the model, between the angiogram of the 3D printed model and the base angiogram to be about 2.86 millimeters, which is pretty accepted within the field. And again, once we validated our 3D printed geometry, we also wanted to validate using in vitro experiments the fluid profiles that we were getting. One of the most common methods for measuring these fluid profiles is using particle image velocimetry. These experimental techniques were not conducted at Duke. They were conducted by one of our collaborators at Arizona State, and we compared how we're doing with respect to fluid simulations once we using our model versus the experimental results. And again, our results matched up pretty good to say, the base profiles, not just in the main branch, but also in the side branches of say a right coronary artery that we 3D printed for as an example. One of the other things that I mentioned before was, why we need these high resolution imaging modalities. And a reason why we need these high resolution imaging modalities is because the base 3D structure of the geometry that we get from these, base angiograms is very important for determining the actual profile of what we're resolving. For example, shear stress, which is an important pro-atherogenic risk factor for say patients with coronary heart diseases, that factor really significantly changes based on how well we're resolving the underlying geometry. For example, if we have a model which from A through F, where we're removing, the access to, all of these 3D side branches, we significantly see variations in the overall, shear stress profiles for the same region that we're looking at, which is why we wanted to rely on a methodology that is extremely accurate, that we can get a lot of anatomic detail from. Now, having, in vitro validations of not just the 3D geometry, but also of, for example, the fluid profiles in an in vitro setup, that is a pretty controlled experiment. We wanted to see how we're really doing with respect to in vivo results. Therefore, we validated our models by comparing fractional flow reserve, which is currently the gold standard of measuring whether a patient should undergo a catheterization or stent or not. Fractional flow reserve, mathematically, it is a ratio between the pressure above and below the region of stenosis, and it can be determined both using our fluid solvers and in clinics. Clinically, traditionally, a cardiologist, or an interventional cardiologist would put a pressure guide wire, introduce a hyperemic drug for maximum hyperemia, and then measure this the pressure profile above and below the stenosis, indicated by PD and PA. We would do it in a computational way in a non-invasive setting by implementing appropriate boundary conditions for a fluid solver, giving it the right patient 3D geometry, and having inserted all of these patient-specific fluid factors, for example, hematocrit, fluid, overall flow rate, and things like that, the pressure. And once we have that at different regions, once we have our simulation completed, we would compute the same quantity FFR using our simulations. These are some of the results that we got. It's from our pilot study. And here what we see is that for the regression plot and the plan-outman plot, we're pretty much within these 95% confidence intervals. We have a good regression ratio too. The overall error was 6.73% when we compared to invasive measurements, and accuracy of over 93%. So these were pretty strong results, which helped us, actually move towards and expand this pilot study to a full-blown multi-center clinical trial with 200 patients. That work is still under review. What I can say is that our results were pretty competitive based on the initial pilot results that we got. Another thing that is pretty commonly asked to us is that how sensitive are our simulations for changing, say, if the patient gets measured velocity, heart rate, hematocrit between different institute, how robust would be our simulations? So we did this basic naive sensitivity analysis, and what we find from here is that anatomy is the driving feature for changing any results between our measured FFR quantities, which was again pretty encouraging. For any other remaining factors, it remained to be less than 1.5% mostly, which was again helping us understand that the models that we're developing, which are non-invasive computational, they're pretty robust to changes. Having a robust model, we were able to not just interrogate what is currently known, such as FFR, but we were also able to find these novel biomarkers. For example, we were able to discover that for a certain set of diseases, coronary diseases, which have complex lesions, as are shown here, for example, a lesion in the bifurcation area, a lesion which is serial, a lesion which occurs right at the ostium, and these, some of these difficult, or when there are collateral vessels present, and in each of these we were able to find that shear stress, which is an important hemodynamic quantity which we can get from our fluid simulation, that was significantly different between non-complex and complex lesions, which is again something that physicians can use in clinics using our simulations to predict how the disease is going to progress. Now, of course, we know that having access to all these models and everything is not is great for us, but may not be viable for physicians to put them in clinics. So we want to enable them with the technology, with a tool that they can use to access some of the data that we're generating, some of the fluid simulations that we have access to. So we thought that virtual reality based devices, which gives like a full 3D view of things, we can 3D view of our simulations, we can give them, and if they can interact without having to access all of these external compute power, it will help them in making use of this information within clinics. So we did a couple of studies with cardiologists and interventional cardiologists to determine if they're using these our simulation results and how well are they able to do it, using two key studies. The first one was identifying the location of stent when we have given them the full 3D physiological map and without giving them the 3D fluid map, with different types of immersive devices or extended reality-based devices as shown here. For example, we gave them an HTC Vive, which is a fully immersive device, a semi-immersive device where we have augmented reality as is shown on the right. Another study that we did on similar grounds was helping them to place a graft, as is shown here, for a coronary artery bypass graft procedure. And what we found that having access to shear stress data was incredibly helpful, as it removed any kind of difference between these different imaging modalities, which actually suggests that if we give them access to shear stress data, which is known to be correlated to disease progression, they would rightly identify the area. Another thing that we found, that if we do not give them access to these maps, then having a tool for them, which is virtual reality or augmented reality based, we found that their accuracy for identifying location of stent, which is determined by distance deviation, significantly improved. So overall, in this first part of our talk, I want to mention that we were able to, really aid clinical decision-making and empower physicians, with significant predictive power for diagnosing patients. For example, here we looked at coronary heart diseases. So the second part of the talk, now we're just getting into, is how can we empower patients and encourage them for any kind of self-management tools using AI. We have access, there are currently over 1.2 billion smartphone users, which is latently collecting a lot of, say the step data, the heart rate, the sleeping patterns, and things like that. Having access to all of these, different modalities of data types, which are related to a patient health, what we can really do is build these personalized and automated persuasive coaching techniques just using AI. Now, when we think about AI, there are a couple of things that we need to keep in mind. There has been a lot of buzz, with what ChatGPT created and some of the other models that are coming out from Google, such as Bard, which is based on the PaLM and the Lambda models out there. However, one thing that we really need to keep in mind is, we want these AI models to be responsible. We want them to be automated, having no human in the loop. But most of all, we want them to be empathetic as well. We don't want any kind of generic statements coming out from these models. We want them to be personalized towards a specific state of a given user. Large language models, both Lambda GPT, GPT-3, ChatGPT, all of these models, they come under this umbrella term called as large language models. We'll learn a little bit about large language models in just a couple of slides. But yeah, before getting into the nitty-gritty details of how these models work, I just wanted to say how we have used them for for actual studies using patients and users. So the first step, without even including any kind of fancy language model, which are more advanced types of AI techniques, we wanted to see how we're doing with simple rule-based ML approaches, machine learning approaches. So traditionally, what has been around for say over 7 or 8 years, using deep learning, random forest, and some of these different ML algorithms. And we wanted to use basic behavior science models. We wanted to empower these ML models based on fundamental behavior science theories. For example, we use the Fox behavioral model. I wouldn't get too much into it, but the goal of that model is to use the motivation, the ability, and the capability of a user to determine how likely they would be able to perform a given task. So we determine these individual states based on the demographics by having this initial conversation using an automated coach that we develop using simple rule-based techniques relying on the Fox behavioral model. And we wanted to see how users respond to say an automated coach. In our case, we called it BASE. And we wanted to see how it's comparing to humans based on a coaching. We did this longitudinal study spanning over 4 weeks, and we found that, whether it was the overall activity, we did not find any kind of significant difference between the different weeks. We also did not find any kind of difference between how the users are communicating with these automated bots that we develop versus humans. What was even more interesting that even the duration of how long people were engaging with these models was also not different, which means that if we give users some of these tools, they're very likely to respond to it, and their end goal, which we determined based on the steps they were taking for say 2 weeks, even that was not different, which was really encouraging. Once we had that automated coach, which was based on simple rule-based techniques and used a fundamental behavior science theory model, we wanted to apply that same behavior science theory model to a large language model, again, which we'll learn about in a couple of slides. Hold on that. And what we found was that if we're able to control the domain of these language models, because these are trained on generic data sets, for example, through web browsers, Wikipedia pages, Reddit pages, which they may not perform that well. But if we prime them, which is a controlling technique for these language models, we found that it can be significantly improved. These models can be a lot more empathetic, they can be a lot more helpful to users, and we found that having an unprimed or a naive language model versus a primed coach-based model, we were able to see a significant difference between how the quality of the conversations that the models were making, the quality of the kind of responses that we got from these models. So overall, in the second part, what we found is that, if we do these studies, if we develop these automated coaches, not only do these models, they're empathetic, personalized, and persuasive towards a given user. But what we also found is that if we expand it to a fully automated way without any rules that it follows, a rule-based technique, but if we constrict the domain using these behavior science theories, we're able to find that they can in turn be used pretty well for making conversations with actual users. Which really brings to the last part of my talk that we have developed different models using both basic mathematical equations relying on physics, and also relying on, for example, say AI-based advanced techniques such as language models. What we're really able to find is that what is missing here is having access to data. Unfortunately, even though there's vast amounts of data that is produced, what we really have is a pretty small fraction of it available to us to train these models, to develop these models, to use in these models. And I mean, it shouldn't be a slight for the kind of audience we have here, but of course the sensitivity, privacy, ethical concerns, and data regulations that are around health data is what prevents us from using these models for either retrospective, real time, or any kind of predictive analytics. And pretty much that is the reason that in the world of machine learning, artificial intelligence, we have seen models that very big models such as ImageNet, WordNet, which have really changed how computer vision or natural language understanding, natural language generation, how these fields have really advanced. However, we do not have a health net yet, which is why we need to really start working on what kind of methodologies do we need in place, so we can actually have access to some of these some of the power that the other fields have been enjoying. And one of the reasons why they have been able to progress so fast compared to healthcare is because there is a lot of open access data set that is available to use for scientists, for machine learning and data scientists to train these models on. One of the ways that we think, or I think that it can really help make HealthNet a reality is using synthetic data sets. Synthetic data sets, they really help us get around, not just the identification, which is a very hard and tedious process, but also, any kind of anonymization or privacy concerns that are inherent to health data sets. Interestingly, what is also important for us to note is that if we have models that are trained on synthetic data sets that very closely represent real data sets, but cannot be traced back to particular say a user or a patient, that becomes really helpful because we can share these models say with different hospitals or different academic institutes, and it can be used for reproducibility, for augmenting data sets, or for having a full diversity of data sets, and really help us interrogate a lot of these underrepresented patient subgroups as well. So this model, it's a very basic machine learning model called generative adversarial networks. This has been one of the forefronts of an ML approach that has been used to create synthetic data sets. I think some of this work came around 2014 or 15, so it's not super recent. These models have been around for say 6 or 7 years and have been significantly applied to a lot of health data sets. Briefly, I'd love for for everybody to just understand it at a very high level how these models work. Essentially, a generative adversarial network, it has two core components: a generator and a discriminator. Both these work in sort of a min-max game. So what the generator is trying to do is trying to create these synthetic samples, which is based on an underlying distribution of what we give as a potential data set that we want to create the synthetic data from. It recognizes, and in addition, we add this noise vector to it. Once we have these synthetic samples, we start comparing the generated samples to true samples, and we ask this discriminator to see, can it differentiate between synthetic samples and true samples? So the beginning, synthetic samples would be pretty bad in quality, but over time, this discriminator would get really good. It would get really good at identifying how different is the generated data from the true data set. And what it would like to do is the generator would like to maximize to fold the discriminator, whereas the discriminator would like to minimize this essential loss term. Once we have this, we'd be able to really reduce this distribution for the red to get very close to the green, so we can start generating synthetic data that looks very similar to the actual true data set. And again, there have been, as I said before, this basic model has been applied to several areas at this point. However, GANs have been really great, generative adversarial networks have been great, but they're really hard to train. They suffer through they have significant limitations with respect to, how these models, for example, again, this is a lot of detail for us to know, but one thing to keep in mind is that we need to train these models, and training GANs can be really tricky because they may not capture the full diversity. They might just capture, one peak of the distribution and not the remaining peaks. Moreover, it's also important to note that when we look at biological data sets, they have these underlying relationships. For example, the kind of diagnosis that a physician does would be related to the medication, which might be related to, different measurements and things like that. So one of the things that we think, or we've been working with and doing with this idea, is to use language model based on transformer architectures, which is what I'm tying back to what we discussed at the during the second part of the talk, which was on large language models. But these language models they've really come out to be really strong. And a few years ago, Google came out with AlphaFold, which was able to solve this grand challenge in protein folding. There have been several, BERT or BERT-based models, which are also transformer-based, and they're being increasingly used, for example, to augment EHR data as medical scribes, summarizing text, and such things. Would it be okay to stop recording at this point, Dr. Matthew?
Yes, we can do it. I just
Excellent.